Hi, I'm Bill Kristol. Welcome back to Conversations. I'm very pleased to be joined again today, back by popular demand, and that's even true in this case. Dr. Ashish Jha, Dean of the Public Health School at Brown, very well-known public health expert, and has consulted with everyone, federal government, state governments, the public, informed the public over this last year in very impressive ways, I think. So thank you for being with us, with me again. We talked, just before Christmas, I think.
Yeah, Bill. So first, thanks for having me back. I'm excited. Yeah, I think it was early December,
Yeah,
and
mid-December, I think. Yeah, late December. Yeah.
yeah,
And that was 2 months ago. And I think I look back quickly at the transcript, and I think your prognosis stands up pretty well. But let's talk about where we are, where we're going, vaccines, testing, what the new normal will look like, the whole thing. So it's February, what is it, 18th as we talk, I think. Where do we stand? I mean, just generally in dealing with this pandemic, and obviously vaccines is the focus of most people's attention.
yeah. So generally, I would say things are looking pretty good. Case numbers are down. So, I mean, since we talked, but they peaked in early January. They're down 60, 70%. Hospitalizations are down 40, 45%. Deaths are starting to move. They always lag. They're down maybe 10 or 20%. But look, that's going to continue going down. So on one hand, it's great. And if there were no clouds in the horizon, I would say it's more or less smooth sailing from here. But there are a couple of dark clouds in the horizon. The variants that you've been hearing about, the UK one, the South Africa, maybe some from the United States. And those are real clouds, and they're going to cause storms, and we've got to weather them. But that said, overall, I feel like the outlook here is still very good, and those clouds and those storms are going to be passing, and we're going to have to get through them. And then after that, things will get meaningfully better.
So you don't think it's likely, at least, that the variants fundamentally challenge the vaccines or us achieving a reasonable new normal?
No, not based on everything we have so far, but here's the little asterisk in this, which is there is this sort of tail and kind of possibility, this low likelihood event that we could get a new variant, not one that's out already, but a new one that is resistant to our vaccines. I don't think that's impossible. Haven't seen it. Don't think it's likely, but we should be prepared for it because the consequences of that are pretty darn catastrophic. So we've got to at least start getting ready, thinking about that issue.
Am I right I don't fully understand this, I've got to say, the epidemiology of this, but that the faster we would have, or the faster we now get to vaccination and to immunity, the less we have to worry about, even from a new variant would then pose new challenges with booster shots, I suppose, and so forth. But am I right that it makes speed all the more important?
Absolutely. So the way to think about it, let's just maybe take a minute to talk about some terminology. There are mutations, there are variants, there are strains. So what are all these different things? These viruses, these SARS-CoV-2 viruses and RNA viruses are notorious for making mistakes. They're sloppy viruses. And 99.99% of the mistakes are irrelevant. They're little mutations, they don't make any difference. When a group of mutations come together and become dominant in some form, you start calling it a variant. And it says, yeah, this really looks a little different than the normal wild type. When that variant takes on new characteristics, what do I mean? It's more infectious, it's more deadly, or it evades immune response. Then we call it a new strain. So I would say the UK variant can be called a new strain because it's clearly more infectious. It does appear, might be a bit more deadly. The South African variant is probably a new strain as well. These things occur when we let large numbers of infections run wild. One of the many bad reasons, one of the many reasons why the whole kind of, the Great Barrington Declaration, herd immunity strategy was so bad was because literally you were giving the virus more chances to mutate. I'm not sure that we want to press our luck on this. And so then to get to your question, the best way to prevent future variants and strains is to keep number of infections low. And that means suppress the virus and get people vaccinated so that we don't get as much circulating virus and therefore fewer mutations, fewer strains, and fewer variants.
And the vaccines suppress infections, not just severity of the response to infections.
Absolutely. And this has been a source of some confusion. And A simple way to think about it is there is mild infections that don't cause any symptoms at all. There's more significant infections that cause symptoms. And then there's severe infections that cause you to get hospitalized and deaths. So overwhelming evidence that the vaccines are close to universal, close to 100% at protecting against hospitalizations and deaths. I doubt it's 100% because nothing in life is 100%, but it's pretty close. Very good evidence that on that kind of middle ground, the infections that cause symptoms, it probably is 90, 95% protective. Maybe, maybe high. And then the question is, what about the mild stuff, the asymptomatic, the I don't barely even notice? We don't know for sure, but I think there's pretty good evidence that it even prevents those, maybe not at 95 or 100%, but maybe at 80 or 90%. That's a pretty phenomenal track record.
And am I right? I got in a conversation the other day, and I hope I was right about this, because I claim to be. Someone was saying to me, well, that is 90 out of 95 out of 100. Is that so great? That means 5 out of 100 people who got the vaccine are going to get sick. And I said, no, that's not what the 95% means. The 95% means that if if 20 would have gotten sick anyway, 19 won't. And so then of the 100, if 20 out of the 100 would have gotten sick, it's only 1 out of 100. Am I basically correct about that, the way that number is being used?
Yeah, and you are right. And it's not, we shouldn't walk around thinking that 5% of people are somehow still vulnerable after getting vaccinated. What we know is the way to think about it, and somebody drew this analogy of like the fortress with a wall outside. And that first wall outside of the fortress is that 95% number that says 95% of times infection won't even really make it in at all. But if you do get infected,
right,
you still have the incredible protection against, and that's kind of the fortress itself, against serious illness. And of course, you got to remember that when I say, when it says 95% protection, 95% of what number?
Yeah, that's what I was,
Right. And if the issue is that there's large outbreaks happening, then you are at some risk of still getting infected. But as vaccines get out and number of infections in the community drop a lot, that 95% protection is phenomenal, because you're going to take a rare event and you're going to lower it by 95%. And even if you are unlucky and get one of those infections, you're not going to get sick or die. I mean, my gosh, like that's as good as we get on vaccines.
Yeah, the denominator, the 95%, is not the total number of people getting vaccinated. It's the total number of people who would otherwise have gotten the disease. So I just find that in common discourse, people are a little confused about that, or at least I.
Yeah, no. So that's
an intelligent person I was talking to had got it wrong, and I mean, he just yeah.
Exactly. So that actually is a really important clarification. It's not of people who get vaccinated. It's of people who would have gotten the disease, which of course wouldn't have been everybody by any stretch, and even a small
right. So, right. If you were just distancing, you probably wouldn't have gotten it, or hopefully wouldn't have gotten it. So, yeah. So it's so okay. So so where does that leave us in terms of the real world and getting back to getting the timeline, I guess, of when the vaccines? What's your judgment of both the supply and the logistics questions first, and then secondly, we'll get to the real world consequences for schools, businesses, and so forth.
Yeah. So let's for a second act like the variants are not there, and let's just talk about vaccine timelines, and then let's put in the variants and then talk about implications. So right now we're vaccinating about 1.7 million people a day, 1.7, 1.8. The major constraint to doing more is not demand, and it's not distribution anymore. It's supply. We've set up Dodger Stadium. We've set up all these Yankee Stadium. We've set up all these places, and they're not hitting a constraint of no one showing up to get vaccinated. The constraint is there just aren't enough vaccines. So it's a supply constraint. That's getting better every day. And right now, based on what we're hearing out of the White House, we are at a point where about 2 million doses a day are going to start getting shipped out. And I think that number could bump up a little beyond 2 million. And we should have plenty of capacity to distribute that many doses a day. And one other issue on this is there are a few states that are still having distribution problems, lots of vaccines sitting in freezer shelves. There's just no excuse for that at this moment. There's no reason to hold back doses. I've been pushing states, if you have doses, get them out. There'll be plenty for a second dose. So I am pretty optimistic that as we finish up February, get into March, we're going to be well over 2 million doses a day going into people's arms. And that means by the end of March, most people over 65 should have gotten their first dose, and many, many of them should have gotten their second. And I also think we can talk about the policy wisdom of this, but I think we can get teachers vaccinated by the end of March. And once we're into April, other high-risk individuals, people under 65, and really almost anybody who wants one into May. So by mid-May, I would be very surprised if people are having a hard time getting a vaccine. And it's entirely possible that the scenario I laid out is too pessimistic, that it could be even a little bit better than that. I mean, it can't be that much better than that, but it can be a little better than that. And there are some people who think even by end of April, anyone who wants a vaccine will be able to get one. I think and when I do the math, I get more to mid-May as that time period, but certainly before Memorial Day, right?
Wow. So even if things slide, you're looking at June, but not at September or something, right?
Not at September. My gosh, no, not September.
Right.
Like things would have to go catastrophically wrong for us to not have anyone who wants a vaccine be able to get that vaccine by July 4th. I'm assuming no vaccine doses from Johnson & Johnson. I think we will have doses from Johnson & Johnson. The FDA is going to be authorizing that, I suspect, in about 8 days. And there aren't a lot of stockpiles, but J&J is going to kick off production, and we will have millions of doses as we get into April, May, June. So there are lots of buffer that I'm building into my timeline. I'm assuming we won't have that an authorization from Novavax or AstraZeneca. Again, a lot of things would have to go wrong for my timeline to be off on that. It's really good news because it means that a lot of life can start returning to normal as we are into spring, certainly by summertime. And that's why I've been hearing from a lot of public health people timelines that feel way too pessimistic to me. And, I reach out to them privately. I'm like, what am I missing? Why? And I think the pessimism is some miscommunication and some expectation setting that they don't want to overpromise and underdeliver. But I don't think that's the risk right now. I think the risk right now is causing people to feel hopeless that this is not going to end, and then people will just give up. Whereas I'd much rather
be irresponsible. I think, I agree with that. You need to get people that's interesting. Do you think the people in government are being a little bit downplaying expectations for understandable reasons, but in a way that's maybe a little counterproductive?
There's the whole what is the right kind of political framework for this? I'm not an expert. I think that a lot of what I'm hearing is too pessimistic.
Interesting.
I think things are going to get better. Again, the one set of dark clouds that we're not talking about that I purposely ignored were these variants. The variants, just take a minute to talk about them. The one that I'm most worried about in the short run is the UK variant. Probably about 5% of the infections right now are from what's called B117, the variant that was initially found in the UK. That number is doubling about every 10 days. And so if you just do the math, somewhere around March 20th, March 30th, it becomes the dominant variant in the United States. The experience of every other country is that as that variant becomes dominant, the number of infections just spikes 2, 3, 4-fold. And that's a pretty scary idea, right? Because if we're at 70, 80,000 infections, you get a 4-fold increase. That's worse than anything we've experienced in the pandemic. So Mike Osterholm, very smart guy, he thinks that the next couple of months are going to be the worst of the pandemic. And I am hesitant to contradict Mike Osterholm because he's so smart and so good, and I think he's wrong. I think he's being too pessimistic because we can see the variant coming. We're going to be doing really good genomic sequencing, and we've got a lot of vaccines out there, and we've got a good amount of population immunity from people having been previously infected. If the variant had arrived 3 months ago, I would have agreed with him. It's arriving at a time where I think we're going to be more ready. Somewhere between my relatively optimistic, it'll be it's not going to be a tsunami. It'll be a big wave, but it'll pass over us pretty quickly. He's like, it's going to be a tsunami that's going to wipe us out for 3 months. Somewhere in between probably is the truth, but I think I'm pretty confident that it's going to be closer to my end. We'll see it. We'll feel it.
Yeah, how will we know? What's the data points you would recommend people kind of look at, or just obvious cases?
So cases are falling. That's going to start turning around. We're going to start seeing cases rise. It'll be a pretty sudden turn. And right now, we're not doing enough genomic sequencing to actually track this. One of the reasons why we call it the UK variant, the UK is where it was first identified. The reason it was identified first in the UK is because they do great genomic sequencing. They sequence close to 10% of all their infections. And just for people to understand what this means, right now, let's say I get a nose swab, it goes off, and the PCR test, simply asks the question, am I infected or not? If I'm infected in the UK, about 10% of those samples are then sent to a second lab that actually sequences the genome of the virus. And we should be doing that. We have more genomic sequencing capacity than any country in the world. This is not like, trillions of dollars. It's literally millions of dollars of spending to sequence all these things. We should be sequencing so we can track these variants. We have not been, for reasons that are mostly incomprehensible to me. But I'm hoping that we're going to see more pickup. So for people out there, you'll hear about proportion of infections that are variants, and then you'll see a pickup in cases. I do think that's going to happen in March. It's just how big, and my hope is it's small to medium, not a huge wave.
So that's the thing so don't be freaked out when you see the curve bottom out and turn back up fairly rapidly, but do freak out if it starts getting up to 3x or 4x of where
it doesn't seem to slow down and freak out. And part of it is, if I said to you it's going to go up, the risk is it could go up 3 or 4x. You'd again come back to the question of 3 to 4 times what? What's the denominator?
Well, fair enough. Yeah, right.
But here's the key. This is one of the reasons why right now we want to drive infections down as much as possible, so that whatever baseline we jump off of, it's a very low baseline. So that's one of the reasons why I've been talking to governors who are like, cases are down 80%. I'm opening restaurants. I'm like, not right now, please. Like, let's get through this variant, and then it will be much easier. We'll have vaccinated a lot of people. Then opening up restaurants becomes much more doable.
And just one on the distribution aspect, which you seem pretty confident is just the normal headaches and glitches and bureaucratic annoyances of not being able to get on the website quickly for now. I mean, of course, that's what a lot of us most experience, since we don't have access. We don't know how many, we don't, apart from just reading the number, we don't deal with Pfizer directly or Moderna and don't know how many vaccines are being produced, but we do deal with the county or state health department and are annoyed that we can't figure out that the website seems jammed up and then that they don't send you an email when they say they will and stuff. But you think that's all kind of the kind of stuff that you've got to expect, but not fundamentally going to damage the ability to get it into people's arms.
Yeah, so it certainly has slowed things down. And what you see is large variations across states in how they're managing this. And I've been talking to states on both ends of the spectrum, and you can see the differences pretty starkly. So let's take a minute just to talk about how we got here in terms of what went wrong with the distribution. And Bill, the last time I was on with you, it was in early December, and I was very optimistic about distribution. So I got that wrong. The reason I was optimistic was because Operation Warp Speed was making promises about number of cases and number of vaccines that would be given out. And I had assumed they had worked through a plan. There was no plan really, or not much of one, for what happens when a vaccine arrives in the state. How does it get into people's arms? And so then much of late December and January, states spent time scrambling, setting up infrastructure. And the frustration for me was, we knew since September that vaccines were coming. There is no reason to be setting up your infrastructure in January. That should have happened. States that have tried to keep it simple, relatively straightforward, have done very, very well in getting numbers out. There are states where every county, every town has their own website. Like, what are we doing? We don't need every county to have their own website, right? You need simple, straightforward registration systems. I think California is kind of big, but you can imagine for other states, you can have a single state login. And then the other part that's been really frustrating, my parents went through this in New Jersey, where they signed up in every county in the state, and they never heard back from anybody. Nobody ever writes back. No one what should happen is, as soon as you register, you should get a little text message saying you're on our system. And then every few days you should get an update. You're number 87 and there are 56 people ahead of you, or whatever. You get my point. So that you keep people engaged and a sense that this is happening. We can do this. There are companies that can do this. It's been very frustrating. I do think the rest of the states will figure this out. But my gosh, there's no reason it should have gone this badly.
Yeah, it's funny. Fairfax County, which was slow, I think, getting going, for a wealthy county that should have access, reason to be able to do this kind of thing. Now, but does this now? You do sign up, you get an email right back, then you get subsequent emails. They don't quite tell you where you are in the queue, but then they tell you, hey, show up at this place at this time. And so it seems like, just judging from our limited experience here, and I think now, but of course, this is the way you're talking about. So Virginia has a statewide system. Fairfax County seems to have had its own system, and we're getting dueling emails now from Virginia and Fairfax County telling us, they're not really dueling, because luckily they don't seem to have affected the actual scheduling, but that, hey, congratulations, Fairfax County is now part of the Virginia system. And then Fairfax County sort of emails you, here's your Fairfax County. I don't know, it's a little confusing, honestly, but as long as you get your appointment, who cares, I suppose. But it's
right. But what's interesting, though, is that confusion and lack of is easy for some people to navigate,
right?
But for other people, it's really tough.
No, that's a good point.
And that's the problem: is complexity and confusion doesn't affect all of us equally. Yeah. And for people who spend a lot of time talking about and thinking about equity, I try to make the argument that simplicity is actually one of the best tools for equity.
Totally.
Because complicated systems means you need additional help, and not everybody can get that extra help.
Yeah, that's really an important point, actually. Okay, so, and not everyone has children and grandchildren who can go, refresh the website every 10 minutes or know how to search different counties, as you say. There are states where it does seem like, or go to Safeway and CVS and see who's got a quicker, faster opening and stuff. It is. Okay, so assuming, the truth is somewhere close to what you think it will be, and I hope and trust it will be, on the vaccine production and then the distribution, where are we when in terms of schools and businesses, and just life in general? And then I also want to get to how important is testing as part of this normalization, and how important is it even for the interim period until we get fully normalized? Because I do feel like testing, you and I discussed this a little before a couple of days ago, testing is like slightly vanished from the discussion because everyone's understandably excited about the vaccines. But anyway, schools, businesses, testing, we can go whatever order.
Yeah, so let's hold off on schools for a quick second. Let's just talk about kind of more, because schools raise some very specific, I think, concerns that we should talk about separately. Okay. But I think the next couple of months are the kind of where I have the least amount of clarity, just because I don't exactly know how the variants will play out. But let's assume that we get through it, or it's mid to late April into May. We should have, by that time, 25-30% of people vaccinated, if not more, a lot of people with immunity. Infection numbers are going to be very, very low by that time. And you're going to start seeing businesses starting to bring some people back. Now, businesses who may not need to bring people back will say, well, we'll do it in the fall. That's fine. But I think you can start seeing retail stores open up much more. And as we get into the summer, a lot of life begins to get back towards a new normal. And I want to talk a little bit about new normal, because new normal people often see as like somehow saying, well, we'll never go back to normal. Well, we won't ever go back to normal because pandemics change societies. And I'm not sure that 2019 needs to have been our most glorious year. We may be able to do better in some ways. In some ways it'll be not as good, but some ways it'll be better. And also new normal for whom, right? And so if you're a guy who sells hot dogs outside at a beach, summer of 2021 should look really pretty close to normal. If you're somebody who runs a Broadway theater in New York, summer of 2021 may not look normal, and it may be more like fall, because and the differentiator is obviously the Broadway theater. It's a tougher thing to pull off because you're indoors, you're in there for a long period of time. It's jam-packed. These theaters are terribly small, and people are singing and dancing, and it's a much more high-risk environment. So it's my way of saying that the normality is a glide path towards normality, right? But that glide path becomes, I think, really visible as we get into late spring, April, May of this year, a couple of months from now. Again, there's always the outside random chance of some new horrible variant that we haven't talked about at all. Low likelihood, assuming that doesn't happen. And so that's good news. And I think people should look forward to wherever they are in April or May. June will be better, July will be better than that. And by the fall, it should be very few things that we're not doing. And I don't even know what those are. But that's then gets into the testing issue. And maybe we can use that as a segue to also talk about schools.
Great.
Testing, I think is the enabler for high risk events. So let's talk about restaurants, for instance. I think restaurants by the summer can open up, but we'll probably need to still do some amount of distancing, because a fully packed restaurant at a time where not everybody's vaccinated, it's a little tricky. It's complicated, and people are not going to feel, because obviously you're not wearing a mask when you're eating. But you could imagine a restaurant that wants to open up fully and kind of at a relatively high capacity could, and it have to be a kind of a higher end restaurant that would have to do this, could instill a test regimen where you have to show up and show that you actually either got a test in the last 24 hours, or they'll have antigen testing available, 5-10 minute turnaround. And what you're doing is you're trying to instill confidence in people coming inside the restaurant, right? That the restaurant, everybody who's going to go into that restaurant will have a negative test and you'll feel better. Restaurants may not be the perfect example. That certainly I can imagine airplanes, that definitely. Long haul flights, I used to fly all the time to Asia. Haven't done that in a year. I don't know if I'm excited about spending 16 hours with 300 random people in a tight cabin. But if every one of those people got a negative test before they boarded the plane, I'm going to feel much better about that. If everybody gets a negative test before they go inside that Broadway theater, I'm going to feel much better about that. Right. So you can imagine that testing becomes the thing that takes what are otherwise relatively higher risk activities and turns them into relatively low risk activities. Because the Broadway theater may not be able to ensure that everybody's been vaccinated.
Right.
And that's what makes it complicated. From a business point of view, companies are going to have to make decisions. Are you going to require that your employees get vaccinated? And I'm encouraging companies to think about that right now, because that question will come up by May, June. And you may say that if you want to come back to office in person, you have to be vaccinated. So I can imagine that, again, over the summer, companies are going to struggle with that. Let's talk about schools, probably the most contentious issue.
Or let me ask one thing about testing.
Yeah.
Do you think we will have the capability we will have these mass-produced, relatively cheap tests that if a restaurant or a theater wants to go the way you just said, it's not going to require ticket prices to double and so forth?
That exists now. We have the technology now. We have close to capacity now. The problem with capacity is a little bit of a chicken or egg. Companies will only produce and make investments to produce these tests if they think there's a market for it. And part of the whole problem of the pandemic has been, and under the last administration, there was this constant, like, the pandemic's about to end, we're about to round the corner. And companies would hear that from the president and say, well, why am I going to invest in something where no one's going to need my product in 9 months? So I want to hear clear signaling from the Biden administration that they also believe that there will be a need. I certainly think there will be a need. And then, and these tests are going to get to a point where they're like $5 to $10 a test. So, so you're not going to have a fast food place be able to do that, but a restaurant where a person typically might pay $50 or something for a meal, all in, they could probably add a $5 test fee and whatever. And a Broadway show, I don't know how much you've paid for your Broadway shows. A few times I've been, it's extraordinary. $5 to $10 would not be the thing that would make it undoable. So I think the technology exists, the capacity to have that much testing exists now. I'm worried about whether the market is going to, initially what will happen is there will be a demand, there won't be enough supply, the prices will be high, but I think over time more companies will get into it. So I'm pretty confident that by fall we'll have that kind of it.
And is pool testing sort of a part of the solution here, or is that a separate kind of issue?
It's a bit separate. Pool testing is good with PCR tests, and you can test large numbers of people. The problem with pool testing is it takes 24, 48 hours to get results. So it depends on what you're using it for. It's perfectly good for schools. For instance, if I've been advocating using pool testing in schools, you test everybody once a week, you'll get a positive, and then that'll mean everybody in that class is potentially it means any one person in that class who's positive will set off, and then you have to go and test everybody individually to see which one it actually was. Pool tests are really helpful when you get a negative result, right? You pool it for 25 people, you get a negative. That means all 25 people are negative. That's the mental model of it.
I mean, it would seem like if you're running a school and 9 of your classes are negative and they just go out about with their business next week, one class maybe has to take a day off and everyone has to get individually tested, but it would be reassuring, I should think, to parents and teachers.
Exactly. Exactly. So that's that kind of testing. Again, I think it's really important that we not lose sight of it, because vaccines are going to be really helpful in getting us a long way back towards normal, the new normal. But there will be some things that'll still be tough. And what testing does is, in my mind, like, vaccines kind of get you, we started at our own 20-yard line, get you to the kind of the opponent's 10-yard line. But the testing is what I think gets you into the end zone. Because at that point, you got testing, you've got people vaccinated. Boy, that's just going to start feeling really comfortable and safe for most of the things that we want to be able to do.
Oh, that's great. Okay, so schools, that's a
Let's talk about
particular
schools.
challenge.
Yeah, one of the hallmarks of this pandemic has been setting up false dichotomies. Is it the economy or is it the virus? Well, it turns out you got to suppress the virus to have the economy back. Or recently on vaccine distribution, was it efficiency versus equity? And for all sorts of reasons, I can make the case that that's a pretty bogus trade-off. And the other one has been teachers' health versus kids' education. And what I've tried to argue with people is, if you set up that dichotomy, which we have, and people say, well, teachers being unnecessarily fearful. And I'm like, okay, but I mean, people act based on how they feel, and you've got to address those issues. And I don't think that all of the teachers' fears are unreasonable. And we can blame the unions, but the unions they're responding to their members. And the biggest bottom line is, at the end of the day, I just want the kids back in school. And I want to do it in a way that's safe for teachers. I want to do it in a way that's safe for kids. And I believe the evidence and this data is very clear that we can do this. So let's talk about what is important and what's not important. Let's talk about the science first, and then let's talk about kind of how this has played out and how I think it ought to play out. If my job was to advise teachers and say, I'm going to only focus on teachers' health and well-being, I would say there are four things, and probably in the following order. Number one would be mask wearing for everybody. I just think that's critically important. Kids, teachers, everybody needs to be wearing a mask in school. Second is you got to have reasonably good ventilation. There is now evidence, and again, I'm not a buildings air expert, but I have spent more time thinking about this than I ever thought I would. But I've been speaking to a lot of people who are. And it is very clear that with really good ventilation, good air exchanges, you can drop that risk of an indoor space almost to the level of being outdoors. I mean, that's what you can do with really good ventilation. Third is testing. I would put in testing in schools and make testing a really important part of schools. Once a week, pool testing or something else like we talked about, that would pick up the few asymptomatic infections and would offer a really good layer of assurance. And then last but not least is vaccines. I don't think vaccines are essential to getting teachers back. Obviously, lots of schools have been back without vaccinating teachers. But I also think, we prioritize vaccinating nurses and doctors because we thought it was really important that they be safe in the healthcare setting. I don't think it's unreasonable to say we're going to prioritize teachers. And so that's my four, and probably in that order. What about hand washing? Sure, hand washing is important, but I don't mean to downplay hand washing. Very important. People should wash their hands. But then people go off on things that I think are less important. 6 feet versus 3 feet distance. In my mind, the problem with that is you need to keep everybody at 6 feet all the time. It's a distraction. I don't think there's much evidence that 6 feet is that much better. But if you put it in as an order, as a requirement, then most schools can't come back full time because they don't have enough physical space for kids. And now you've pushed everybody into hybrid. The latest CDC.
You would be okay. Masked students and teachers 3 feet away is good.
Mask, good ventilation, and testing. I think it's very reasonable. Part of it is I'd much rather emphasize the things that matter, like ventilation and testing, and not get distracted by things that are at most on the margin, the 3 versus 6 feet. Something that's not even on the margin, I think it's a distraction, is all the focus on deep cleaning of surfaces. The CDC report talks a lot about things like the recent one talks about like cleaning playgrounds equipment. Total distraction. Like playgrounds, I don't know if there's a single recorded case of a SARS-CoV-2 infection from playgrounds. I mean, sure, like if somebody coughs and sneezes on the playground, don't lick it. But I think that was advice I was giving my kids before the pandemic, right? But short of that, it's just not a thing. And the problem in this pandemic has consistently been that there's so many different ways you can think about it. We end up getting distracted by things that don't matter so much and fight about them. The fights about playground equipment. I mean, stop it. Like, no, playground's fine. It's good.
Shouldn't
And
CDC be saying what you're saying now, rather than, as you just cited, a CDC report saying playgrounds are a big problem?
yeah, I think they overemphasize it. I think the CDC report was not as helpful as it could have been. I think it underemphasized ventilation. Ventilation to me is, after mask wearing, the most important thing. It made a big deal about the 6 feet versus 3 feet. And I thought that was unfortunate. You know, Rochelle Walensky, who's the head of the CDC, has actually been one of the people who's been advocating that 3 feet is fine.
Yeah.
And
she's only
has
been in charge for like 2 weeks, so presumably she,
right.
You know, maybe that's
Yeah, I don't know. And it's not about her. She's been fabulous overall throughout the whole pandemic. But I think there's no question that, you know, I think about it when I'm in the hospital, I'm wearing a mask. Everybody around me is wearing a mask. We're not 6 feet. We're like,
right.
You know, we're all cramped in together, and we don't see big outbreaks in hospitals.
As someone I know who's an emergency room doctor said, if it was easily transferable on surfaces or at 6 feet, even wearing masks, or in that case, you know, more even better protective equipment, there wouldn't be a single doctor in America who hadn't, or nurse or hospital technician in America who hadn't gotten COVID,
exactly.
right?
Exactly.
And they don't. I mean, they had a lot of challenges, and it was bad. They're terrible in March, April, May, and so forth. But it's pretty obvious that it's not being easily transmitted by just opening the door to the hospital, right?
Exactly. And, you know, I went into the hospital in October. I had to get this one procedure where I stayed overnight. And during that time, I was masked up the whole time. Everybody else was masked up. And nurses and other people coming into my room, and we were spending time, you know, during the procedure, like I was in a small room with like 8 people for 4 hours. The point is that it's safe. Like, yeah, otherwise everybody would be sick. I do think there's some other things on masks. Like, we could probably upgrade the quality of masks for teachers and even students, and that'd be good. So, like, let's do the things that'll keep teachers safe. Let's not turn this into a, you know, teachers' health versus kids' education. That's just not a useful framework. It doesn't land us where we want to be.
So if the head of the school system here in Fairfax called you up, and all things equal, and they could get the testing they wanted, and that's a question, I guess, can they?
Yeah.
You would be pretty forward leaning in terms of, let's get back to in-person instruction sooner rather than later.
Absolutely. But let's do the things I just laid out.
Right.
And, you know, and I do talk to school districts a lot, and they're like, well, ventilation, we haven't. I'm like, well, first of all, you've had a year to work on ventilations. I don't know why you haven't, but fine. So get going now. And the ventilation is not like requires some super fancy, like, there are all these like companies with these, you know, blue UV light. No, you just need some reasonably good filters. You need some portable air purifiers. And again, I'm not an expert in this, but there are people who've like
right.
written this all out, very well detailed. It's not going to break the bank. There's money in the latest congressional relief bill for schools. And my take has also been like, this is the one place we should not skimp. Like, let's just get to schools the money they need to do all of this, and then let's get it done so we can get the kids back in and make teachers feel safe.
And what do you think actually is going to happen in terms of the timetable of schools reopening? You're in touch with so many of these districts and governors and stuff.
Yeah, I'm worried, Bill, that we're going to spend a lot of time fighting over things that are not going to keep teachers safe, are not going to help kids get back in. If you look at this latest CDC blueprint, it's not even totally clear that we can get kids back in full time in the fall. And I mean,
if one followed the
CDC's blueprint, I think that to me it's all a travesty having kids be remote for this long. And if this ends up spilling into next year, and if in next academic year you don't have everybody back in full time, I just think that's unbelievable. And by the way, let's be very, very clear about the effects of this. The effects are going to be borne by two groups of people. Minority and poor children are going to be way disproportionately harmed in terms of educational achievement, and women are going to be way disproportionately harmed in terms of labor market effects. We know do all the talk we want about gender equity. We know it's women end up doing most of the childcare, and when kids are going to be home, it's going to affect women's ability to work. It's going to affect the women's ability to progress in their careers. the effects of this stuff is going to be massive. I would like to see us try to get back to in-person learning for most schools this spring. That's what actually President Biden has said. He said, schools open within 100 days. I think we have all the capability of doing that. We should just figure out how to do it. And we should not even be talking about remote or hybrid in the next academic year. We have more than enough capacity to get everybody back safely by next fall.
Yeah, that's interesting. So we should push for that and push for the money, I suppose, to make it easier for them to do it, and the testing that would make it a lot easier for them to do it.
Yeah, and these are not like, it's not cheap, but again, we're talking about $1 trillion stimulus bills. So in that context, a few billion here, a few billion there, like it is money, but this is such a huge benefit societally and letting people work, and it's just massive, massive impact.
No, and there's a lot of money in this new bill, assuming the Democrats can push it through on reconciliation for state and local governments, which presumably is mostly for schools. Or at least a lot of it is. And so, that excuse should go away somewhat, I think. And, well, that's interesting. So we got to push harder on the school thing, and CDC is not quite yet out of what you would regard as too cautious and
the funny thing about the recent CDC report was that if you looked at it purely from a can we get kids back to school, it wasn't a particularly inspiring report. And if you looked at it purely from a can we keep teachers safe, it wasn't a particularly inspiring report. So I think that's what baffled us, is that there has been this dichotomy set up, and it wasn't like it was on one side or the other. It was too pro-union or too anti-union. It wasn't at either of those. It didn't feel to most of us in the public health world who looked at it as being particularly well grounded in the evidence and science. And that was a bit disappointing.
Yeah, that is disappointing. Okay, well, after this conversation comes out tomorrow, they'll all snap to it, and maybe they really will, incidentally. And I'm sure you've been in touch with them anyway, and I'm sure they're getting a lot of feedback from the public health world and from a lot of parents who want their kids to be able to go back, and who are reading you and your colleagues and others, more Emily Oster, people who aren't professional public health types, but have been very strong on this. And I've got to think the political pressure will push in this direction. But we do need the public health people. No one wants to override oh my God, you're killing people. So you need to.
No, and it doesn't, and it won't work, right? So this is the point I've been making, is that imagine we go back to school without those safety precautions that I've laid out, and you start getting teachers who end up getting sick. That's not going to be sustainable either. And I don't want to experiment with teachers' lives. I think there's a way to do this that can absolutely put teacher and staff safety and kids' education completely aligned.
And in any case, it sounds as if for both K through 12 and I guess preschool, but also then colleges, universities, you're pretty confident that by summer and certainly fall, we should be back in not in hybrid anything, just in actual normal education.
Yeah, though, and what it's interesting. So I'm talking obviously at Brown. We've been thinking a lot about what. So we were in person in the fall. We're in person in the spring. But talking to our university leadership about what's going to be different. The 500-person class, those occasionally large introduction classes, that may still be a bit of a challenge. And we just have to think about, do we want to pack 500 people into it?
Yeah. Well, and those are the classes that honestly, how much is this presumably a lecture without a heck of a lot of class participation?
Yeah.
Why not just give the lecture, online and then let people be in the 20-person sections or.
Exactly. So that's where I actually think that the new normal is probably better than the old normal. And where now let's not do those large lecture halls and instead do something that will be just as convenient or be even better doing it online. And then, as you said, the small groups is where it's really at, and that you can continue to do. So I think universities are going to still do a little bit of adaptation to the pandemic and once we get in the fall, but really around the edges, kids should be back, students should be back full time. And it should
sort of in dorms that are not that unlike the ones they were in, and going to eating halls, not unlike dining halls, not that unlike the ones they were doing before, and not wearing masks all the time, or
correct. But here's a couple of questions, right? So one of the questions that I've been asked by several universities is, should we require that every student is vaccinated, every staff is vaccinated, every faculty member? And my personal take is it's a policy decision. But personally, I would feel more comfortable being in a university where I knew everybody around me was vaccinated. I'd feel more comfortable walking into a meeting, knowing everybody was vaccinated. Would I quit my job at Brown if they said that we're not going to require it? No, like I think but I do think it's better if universities can push people to get vaccinated and give reasonable exemptions, but general hesitancy exemptions, I'm not a fan of. I want to move on from this pandemic, and I don't want to have to be dealing with ongoing outbreaks and shutting things down because a chunk of people have chosen not to be vaccinated.
And how much do you think we'll be carrying around our vaccine cards? I got my first shot, and I got a card from Fairfax. I mean, more of a card telling you when to expect your next one, but I guess it could become, or be turned into pretty easily a card you carry in your wallet. Or is that going to be something we'll all just do as a routine matter in case someone wants to know that we've been vaccinated?
Yeah, and what's going to be interesting is I think there are going to be authentication approaches for things. And, I can imagine, for instance, I think about when I used to fly, my TSA number, pre-check, all that stuff was in my profile. And so I would not be surprised if at some point I have to upload to my profile for international flights, my vaccine status. Yeah. And once I have it uploaded and it's authenticated, then that will change my flight stuff. So yeah, I can imagine that kind of stuff becoming common.
And we of course do that already for schools for K through 12. Yeah. I mean, you have to show, as I recall, your kids have had the regular vaccinations they get when they're little and so forth. Or maybe there's some unusual excuses or permissions not to, but interesting. One question, this is slightly a sidebar, then I want to get to one or two other issues. The therapeutics, I mean, again, the vaccine's been so dominant in terms of the news. We made quite a lot of progress on that, it seems like, in the latter half of 2020 in terms of actually treating people who got sick. Is that, are we where we are and that's a pretty good place? Is there future progress on that, or what's your sense?
So I think therapeutics have been a bit of a disappointment. We did make good progress. So on one hand, let me be positive, but then also get to you my disappointments in it. So where are we right now? We have a couple of drugs that really do work very well for advanced disease, dexamethasone, the steroid being one of them. One probably very substantial reason why deaths have gone down, but mortality rates have gone down. But the truth is that it's not enough. There's remdesivir, which may or may not have some benefit. Monoclonal antibodies are these infusions that you can get as an outpatient. They do seem to prevent hospitalizations. You got to give them really early. The holy grail has always been oral therapy. An early oral therapy. I get infected, I feel terrible. I take a 7-day course of some antiviral and I recover. We don't have that. And I think, obviously there was a lot of interest in things like hydroxychloroquine. It got people distracted. I still am hopeful that we will see more therapeutics. And actually, I'm asking, I think NIH did enough, did some, but not enough on pushing for more of that. Because the point is that we will still be dealing with this virus every once in a while. It'll get little flares, occasionally be infected people. Vaccinated people will get infected. Wouldn't it be great if you also knew that if you did get infected, there was therapy and it was going to prevent you from dying, right? That would really add a lot. And I think we're going to get there, Bill. I think it's going to take some more time. I guess I remain optimistic, but I wish we had invested as much resources into therapeutics last year as we did into vaccines. We just didn't. So I would call that an incomplete work in progress.
And it sounds like that if that work gets advanced a little bit and the other things you've been advocating and hoping for and expecting, really, I think at this point happen. I hate to use this analogy, it was so misused by President Trump and a lot of his people, but it's just the flu. But I guess it could become like the flu in the sense that it remains a threat. People get it, and the vaccinations aren't 100%, and not everyone gets the vaccine, maybe, but it might. I guess the vaccines do we know yet if they require annual re-up the way the flu does, or is it? But anyway, it could be. Would it be like, would living with a vaccine be sort of the way we live with the flu today?
Yeah, I think
not the vaccine, living with the virus. Yeah.
Right. Yeah, I think we can get to a point where we can make this virus even less of a problem than a seasonal influenza. Seasonal influenza, about 1 to 2% of people who get infected end up getting hospitalized, and about 0.1% or a little bit less than 0.1% end up dying. I think we can do even better than that with vaccines and therapeutics. But let's say we can get it to that at least. then, the flu is a problem and we deal with it and it affects our society. Hospitals get full and we don't like it, but we don't like shut down our economy for it, and we need not. And I think I think we're really close to getting us to that point. I don't think we need a lot more scientific breakthroughs. We do need to execute on a bunch of stuff. On the question of annual, we don't know about the length of duration of these vaccines. The way I've described it, because occasionally you're hearing something in the news that says, "Oh, it's only 3 months." I'm like, no. The way I think about it is it's going to last at least a year, but I'd be surprised if it only lasted a year. It's not going to be lifelong. And I'd be surprised if it was even multiple years. So somewhere we're going to sort this out. I would not be surprised if in the first couple of years, Bill, that we all get our annual booster, and they may be making tweaks to the vaccine during that time for new variants. And then my guess is at some point people are going to figure out enough about generating long-term immunity that you will get a vaccine and maybe it will last us 5 years. And then part of your at 5 year, you're going to get the thing from the doctor saying, you got to come in for your COVID shot.
Right.
But that'd be fine. Even annual, I think is fine. I mean, I get my flu shot every year. I don't mind getting a COVID shot on top of that.
Okay, well, that's encouraging. Let's talk, this is not, of course, confined to the United States, this virus. It didn't start here and it's an international global public health challenge. I know you've been working on this. Say a word about the whole global situation and how we should think about that.
Yep. Yeah, so I always remind people it's a global pandemic and requires a global solution. And there are some risks here that we should not underestimate. So let's start at a very high level about why it's just a good thing for us to think globally. From just the fact that, America has always been a very generous nation, a country that has engaged in the world in productive and helpful ways. Certainly our global health track record has been, I think, very, very strong over the last 20 years and deeply bipartisan. I mean, the most successful global health program, arguably the last, half century, but certainly a large chunk of time, was by President George W. Bush, and it was PEPFAR. And PEPFAR has saved tens of millions of lives. And so very bipartisan and very much, I think, in line with our values that we want to be good citizens and we want to be people who are helpful to others. That mindset, I think, is important. I think it's not going to be enough. Because the problem is we're coming off of a Trump team that saw the world in very weird ways. And I say weird because this America firstism, I think it's not in line with our tradition. And to have that approach in a global pandemic just makes particularly little sense. And so, of course, we're going to rejoin WHO. We should make reforms in WHO. WHO is not the organization we want it to be, and I think it needs work. Yes, we should contribute to a global vaccine facility that helps vaccines get out. The problem is I think it's not enough. I think it's not enough for the following reason. What I worry about, that sort of the black swan event, I mean, as though this pandemic has not already been enough of a black swan event, but the next black swan event is imagine it's fall. Imagine what we have talked about is all true. We're going to Broadway shows, schools are back, life is okay, occasionally dealing with some testing and occasional mask wearing, but mostly it's fine. And out of India or out of Brazil, there's a new variant that is truly resistant to our vaccines. That variant will show up in New York or San Francisco or LA or Miami, right? Or Detroit. It will spread across the country. And all of a sudden we will find ourselves sitting ducks, vulnerable to a new strain of the virus, going, oh my God, we got to build a new vaccine for this. We got to distribute it again. We got to shut things down for a while to keep the virus under control. This is the unlikely, but nowhere near zero likely nightmare scenario. So how do we prevent that? Because none of us are interested in repeating what just happened. The way we prevent it is really straightforward, which is we get the world vaccinated reasonably quickly. Just as we've been talking about how do you manage variants in the United States, suppress the virus and get people vaccinated. What the Biden administration needs to do, and I'm going to put it on the Biden administration because nobody else is going to do this. WHO can't do this. The Europeans aren't going to do this individually. The Biden administration needs to lead a global coalition of countries that invest in and totally rethink our vaccine production so we can get large chunks of the world vaccinated this year. And I think it needs to use its, and I'm getting out of my lane here a little bit talking about foreign policy, but needs to use its foreign policy power, the soft power it has, to lean on countries to suppress the virus. Like Brazil has just had a horrible time, and Bolsonaro continues to let the virus run wild in many places. That's not okay. It's bad for the people of Brazil. Lots of people have died. It's also just bad for the world. And part of our diplomacy should be, hey, let's get this under control. We can help. And the kind of resources we're talking about are, again, rounding errors in the global hit of this pandemic and even to our own budget. But the risk for the Biden administration is that they're going to compare themselves to Trump. And they're going to find that everything they're doing is dramatically better, because it is. It just may not be enough for the moment in front of us. What we need is not to be better than what the Trump administration did. We need to be deeply engaged on this topic. Right now, we're on track to vaccinate the world by 2023, 2024. That's too long for this virus to run wild the way it has. We've seen the rise of these variants in less than a year. I don't know that I want to give the virus 3-4 more years of running wild and hope and pray that it doesn't end up grounding us again. So a global strategy consistent with our values as a good global citizen, but also deeply, deeply important if we want to move beyond this pandemic.
And you think other countries have the infrastructure and so forth, some of them with some financial help, I'm sure, from us, to do this? This is not just a pipe dream, though, the idea that you could basically vaccinate the world.
No, in fact, the vaccination infrastructure in most low and middle income countries is much better than ours, because they do this. They do mass vaccine campaigns.
Right.
So that part is not the problem. To me, the problem, some places will need some help, and I'm not even sure we're the right people to help, but where countries clearly need help, the world needs help, is in production. We've got to just make billions of doses of these vaccines. We've got to make them relatively quickly. And what that means in my mind is President Biden should call a meeting of the major global vaccine manufacturers and others and say, look, like, we're on track to make, whatever number of hundreds of millions of doses this year. We got to go 10x. So this is not can we tweak the formula to get 10% more? We've got, 10x, 5x, some large increase. How do we do it? And where are the resources? And by the way, and that's not something America has to pay for by itself. I think the Europeans and a lot of other countries will kick in resources. But I think you do need a different approach to production. We don't have it right now, and we're not producing these vaccines fast enough.
So not a huge sigh of relief and relaxation in September, but rather continued vigilance here, but also a real focus on vaccinating the world, it sounds like.
Yeah, and I think if you want to really relax in September or over the summer, you got to keep one eye on the rest of the world, because global pandemic, right? Like it really is.
Well, the variants, as you say, we call it the UK variant and the South Africa variant. It's a little imprecise because, of course, they have scientific names, I suppose, but
yes,
that's where they popped up and from where they came to us. So it does a good reminder that it's not just China and Wuhan where these things can start. Or
absolutely. And I also remind people that you have not heard about the variant from Singapore or Japan or South Korea, because there are no variants from there, because they've managed to suppress the virus. If you don't give the virus a chance to mutate, it can't form variants. So there's like a basic science here. And the science is you give the virus lots of chances to replicate. It will replicate, it will create variants, because that's how evolution works. And so we already have very clear evidence of where these things will arise. And our job is to stop giving the virus so many chances.
It sounds like this is one of the core arguments, in addition to more straightforwardly humanitarian ones, I would say, against the sort of glib invocations of herd immunity 6 months ago, whatever that was, the Great Barrington Declaration, which you mentioned, right? That you're really not, it's not just a question of trade-offs of the economy versus some more elderly people getting sick or even dying, that you fundamentally change the balance of the equation in terms of the virus itself.
Absolutely. It's essentially was hey, let the virus win and hopefully we'll come out okay. it was one of those things where it was shocking to me that a few reasonably smart, well-educated people would subscribe to the theory. It was one of those theories, Bill, and we've all seen them in policy, which I often say, like, it's something that sounds good until you think about it. Their approach sounded really good, like protect the vulnerable, open up the economy. All sounds right. Who doesn't want to protect the vulnerable? Who doesn't want to open up the economy? That all sounds right. But the moment you start playing it out and say, well, what will this mean for how much infection there will be? Okay, you get herd immunity. By the way, herd immunity without a vaccine, at that time we didn't have a vaccine, doesn't last, because guess what? People die and new people are born. And over time, you start getting more and more people who don't have natural immunity, and then they have to get reinfected. And like, this is a lifelong, like, letting kids get infected strategy. Like, what are we doing? So it was one of those things where it was a bunch of serious people making a bunch of unserious arguments. And we all paid too much attention to it. And partly because of Scott Atlas. I mean, Scott Atlas was enamored by it, and Fox News was enamored by it. And therefore the president got enamored by it. And all of a sudden it went from this kind of fringe theory that no serious person would have taken on. And all of a sudden we all had to deal with it.
And it affected actual government policy there for, don't you think,
Months.
for months of the Trump administration? Yeah,
Absolutely.
yeah, that's unfortunate. Well, let's hope we don't go through that again. I'm sure we'll all make mistakes, but not that kind of willful mistake, perhaps. Hopefully, in the next year or two or three.
Yeah.
Any other? This has been terrific, and I think we've covered most of what I thought we would cover. Anything else we should be covering, or anything you want to tell people, either if President Biden's watching this, or the head of the Fairfax County public school system, or citizens, or parents, grandparents, trying to figure out whether they can have Passover Seder or Easter dinner with their kids and grandchildren?
So what I would say as a final thought is we all should be very, very optimistic about the future. This pandemic will come to an end. All pandemics come to an end, but this one will too. We have, as I said, we have some tough days ahead in the next couple of months at most. And may not be the only tough days. There may be something else in the future we may have to deal with. But largely, we are on the other side of the mountain coming down, and things are going to get better, and life will begin to get back to normal. And people should feel optimistic about that. And these vaccines are extraordinary, and people should feel really excited about that. We should also, by the way, use that to remind ourselves that investments in science really do pay off for us at critical moments. And we have some more work to do on getting us through the next few months. We should do those things, and then once we get through, let's do it. And and questions of like Thanksgiving and Christmas 2021, yeah, like those will be great. But I'm looking forward to, I've talked about backyard barbecues over the summer, indoor dining, probably later summer, certainly by fall. It's going to get better. We're going to get through this.
Good. From your lips to God's ears. And I think in this respect, usually that's said when people are skeptical, but I'm saying it as someone who's believing, because your analysis has been so good, honestly. And you haven't been at all Pollyannish for most of the time in 2020, right? I mean, so you were alarmed when it was right to be alarmed, but hopefully we're, as you say, on the other side of the mountain. But still a lot of policies need to be gotten right on schools and so forth, and a lot of things can be improved in distribution, and
absolutely,
as you say. So still a lot of work to be done for everyone. Well, look, Ashish, thank you so much for taking this time. I know how busy you are, and this has been, for me at least, a very informative conversation. And thanks again for joining me.
It was really fun. I enjoyed it again, and thanks for having me back.
My pleasure. And thank you for joining us on Conversations.